You reach up to grab a plate from the top shelf, slide into your jacket, or try to find a comfortable position to sleep. Suddenly, a sharp ache bites into your shoulder, bringing your movement to a dead stop. When that happens, almost everyone shares the exact same physical instinct: try to stretch it out. But if you force a painful shoulder through a heavy stretch, you risk driving the irritated, swollen tissues tighter against the surrounding bone. The core mistake is treating the shoulder like a single generic hinge. In reality, it is a highly sensitive suspension system of floating bones, microscopic clearances, and delicate counterbalancing cables. Different mechanical failures require entirely different repairs. Let's figure out exactly which part of your suspension system is failing right now. We are going to run through 3 simple diagnostic tests you can perform right where you are, sitting or standing. By pinpointing the precise mechanical breakdown inside the joint, you can stop applying blind force and actually give the shoulder the specific input it needs to heal. Test 1 is the side lift pinch. Let your arm hang relaxed by your side, then slowly lift it straight out away from your body. If you hit a sharp catch right in the middle of the movement, and the pain suddenly vanishes as you lift past it, you've identified your pinch zone. This 2D cross-section shows exactly why that middle range hurts. Notice the narrow gap between the arm bone and the top bone. As the arm rotates upward, the gap narrows. Tendons and bursa sacs inside get tightly squeezed against the hard ceiling. Fixing this means taking the lifting muscles offline completely. You start by resting your good hand on a table, letting the sore arm hang heavy, and doing small gravity-assisted pendulum swings. Next, you sit at a table and slowly slide the arm forward on a towel, letting the surface support the weight entirely. This is a space problem. Curing an impingement is strictly about creating physical clearance in the joint by decompressing the bones, not aggressively pushing through resistance. Test number 2 is the empty can. Hold your arm straight out, angle it slightly to the side, and turn your thumb down like you're pouring out a beverage. Now try to hold it there while someone gently pushes down on your wrist. If downward pressure causes pain or weakness, look to this vector model. We've isolated one specific muscle, the supraspinatus. It acts as the critical lifting wire, taking the brunt of the tension every time you initiate a lift. When that wire frays, lifting anything is a mistake. Recovery relies on sliding your forearms up a wall for total support and using very light, static outward presses against a door frame to rebuild strength without letting the joint move at all. This is a load problem. A weakened supraspinatus requires extreme patience to slowly rebuild the tissue's capacity over weeks. Rushing the process with high intensity will instantly derail your recovery. Test number 3 is the outward turn. Tuck your elbow tight against your ribs, bend it to 90 degrees, and try to rotate your forearm outward against a wall. A sharp ache in the back or outside of the shoulder points to our third failure. The modern world dictates the mechanics of our bodies. Typing on a laptop, steering a car, cooking a meal, scrolling on a phone, virtually every daily action forces the arms forward and constantly pulls the shoulder mechanics inward. Because of that chronic inward pull, the opposing muscles in the back of the shoulder, the external rotators, spend years stretched out and neglected. Eventually, they weaken to the point of failure. You correct this by waking up those neglected counterweights. Hold a light stick with both hands and use your healthy arm to gently guide the sore shoulder outward. Once mobility improves, strengthen them by lightly pressing the back of your wrist into a wall. This is a balance problem. Eliminating this specific ache requires actively fighting the chronic, inward slumping posture of daily life and deliberately restoring tension to the back of the joint. If you tested positive on multiple branches, do not try to do every exercise at once. Pick the single test that most closely matches the pain you feel during your real life and start exclusively with that specific set of movements. Stick to that targeted routine once or twice a day for exactly 7 days. Give the joint a full week to adapt to the mechanical input before you evaluate your progress or consider adding in the other exercise branches. There are hard exceptions to this flowchart. If your pain started after a sudden fall, if the shoulder feels so unstable it might slip out of the socket, if intense aches regularly wake you up at night, or if you see zero progress after several weeks of careful exercises, you stop the physical therapy. These red flags point away from mechanical irritation and towards severe structural damage like a fractured bone or a torn labrum. Those require a doctor and medical imaging to properly diagnose. But for the vast majority of people, the shoulder is a perfectly readable mechanical system. By listening to the precise feedback of these diagnostic tests, you apply the exact fix to the exact problem, and you earn your mobility back.